Thank you for joining us for another episode of Scientifically Speaking, where we're in conjunction with Modern Aesthetics Magazine and Practical Dermatology Magazine. Today, we're going to be talking about radio frequency in aesthetic devices. And with us, we have Dr. Vic Ross, well-known laser expert and dermatologic surgeon from Scripps Clinic in San Diego. And then Dr. Erez Dayan, who's a plastic surgeon up in Reno, Nevada. Thank you both very much for joining us.
Thank you for having us.
Thank you.
So as is customary on Scientifically Speaking, where we get to know one another a little bit when we start, Dr. Ross or Lieutenant Colonel Ross, can you tell us a little bit about your ball cap that you're wearing tonight?
Well, I'm wearing this ball cap in celebration of my oldest daughter getting into NYU medical school and starting in 1 week. So that's the story there. Virtual medical school.
That's incredible. So, and then from what I understand, NYU is a school where the tuition is completely subsidized by the university. So congratulations to you for many reasons on that.
That's very good. When I go by Home Depot, I give him a little salute and thank Mr. Langone.
Yes. And what about you, Erez?
Well, you know, my oldest kid is only 4 years old, so I can't celebrate their medical school admission yet. But I'm a young plastic surgeon, and you know, radio frequency for me has really kind of defined the early portion of my career. I do a lot of it in office. So in a way, my cap is similar. This is an InMode cap, and I use many of their devices and really benefit from, a lot of the patients benefit from bipolar radio frequency that we use. So I dug up, as I mentioned, Joel, I don't have many caps, but this is one I keep in my office, so I put it on for you guys.
Excellent. So I'm a dermatologic surgeon in Denver, Colorado, but I grew up in metropolitan Detroit. And my wife went to University of Michigan for undergrad, med school, and residency. And growing up in Michigan, I was a huge Michigan fan. I still am. Our idea of an ideal weekend would be going to catch a Michigan football game, a Michigan hockey game, and a Zingerman's Deli all on the same day. So I'm wearing this in salute to University of Michigan athletics. And my two nephews are actually supposed to head to Ann Arbor to attend university as freshmen. We'll wait and see what's going on with on-campus, in-person learning over there. So tonight we're going to be actually talking about radio frequency. And this is an exciting topic because there's a lot of different devices that are used in aesthetics. So we have bipolar fractional radio frequency, we have monopolar radio frequency, and then we have bipolar radio frequency that isn't fractional. And people use these different devices, and many people have all of these devices. And I think Dr. Vic Ross has been really one of the innovators in the world of energy-based devices and knows these technologies better than anybody else. So Vic, you know, when we start out, we conceptualize how radio frequency works and what types of devices are available. Can you run us through your thoughts on this?
Yeah, absolutely. The initial radio frequency device, well, of course, Bovee created radio frequency many, many years ago and unfortunately died, a poor non-tenured professor at Harvard. But 100 years later, 120 years later, there was a device called Thermage, and I was involved in the animal studies with that in the late 1990s. And this device really was the first so-called skin tightening device that involves aesthetic radio frequency. And that was a monopolar device, which we had a return electrode in this broad sort of dielectric that actually provided and emitted radio frequency energy with simultaneous cooling to heat the skin from inside out. And then we have these bipolar devices, some with rails, some with needles. And those are the two basic types of devices we have. And so we have bipolar, monopolar, and everything in between. There are devices called multipolar, tripolar, which largely are just modifications of older technologies or a little bit different configurations. But the whole radio frequency world is a little bit confusing. And I think part of that is because, in fact, it's harder to understand radio frequency tissue interactions in many respects than laser tissue interactions because of just the nature of the skin, the nature of the path of electricity, and where and what the electricity heats.
So thank you for that. So Dr. Dayan, you know, when it comes to radio frequency in a plastic surgeon's practice, you know, some patients you look at and they have enough redundancy where you're really looking at them and saying they'd be a better surgical candidate. For other patients, you're looking at them and saying, you know, honestly, maybe they're expressing a desire for a non-surgical option. You're thinking maybe you could actually give them some results with a non-surgical option. How do you walk through this with a typical patient in this respect?
Well, I think what you bring up is really kind of the key issue is really what does the patient want? And a big part of that is what they want in terms of results. But, as I think as our lives get busier, um, really downtime is a key part of that. And incisional burden is also a key part of that. So, for me as a younger plastic surgeon who has really gotten involved in energy-based technologies and radio frequency, I find that there are many patients in this kind of what they call treatment gap group. So, we have young patients, middle-aged patients, and older patients. And I think for sure, patients with a lot of skin laxity, massive weight loss, that group really needs an excisional traditional operation. But there's so many people in their 30s, 40s, 50s, kind of this middle group that are actually very happy with a 30% improvement, some skin tightening, some soft tissue remodeling, without incisions. So for many people, that downtime, incisional burden trade-off for less of an aesthetic result, it actually works very much in their favor. So they actually prefer radio frequency technology.
Dr. Ross, when it comes to a dermatologic patient coming into our practice where you and I both don't do facelifts, we may do other significant procedures that have downtime like laser resurfacing, we have the opportunity to do other types of technologies on these same patients. And one of the ways that I've integrated radio frequency into my treatment regimen is people who have extensive secondary smile lines in this area, or people really who have a lot of laxity around the mouth. I think with full field heavy resurfacing with erbium mixing with fractional CO2 or fractional erbium, we do get some tissue contraction, but we can often precede that with radio frequency as well on that same session. So where do you find it most effective to use radio frequency in your practice, taking into account that you are a laser expert and do some of these big procedures and train people all over the world?
Well, that's a great question. And I think like Dr. Dayan said, many of my patients come in and they're sort of past the point of not having surgery. And I discourage those patients from doing energy-based types of technologies. But if patients have a lot of problems with the skin surface and have a lot of solar elastosis, there's no radio frequency technology that really addresses that very well. And that's where you really need to use your erbium mag or CO2, either full field or fractional. And I think of it as a layered technique. And then you use that as your superficial device. And your deeper device could be radio frequency microneedling, or possibly something like Agnes, which is a monopolar but needle-based technology to focus on heating certain places very, very specifically. But a lot of the patients need both. They need the deep tightening and they need the superficial resurfacing to sort of do the foundation of the house and the sort of paint on the house.
So Erez, are there people that are surgical candidates that maybe you see in follow-up that you do some subsequent tweaking with radio frequency as well? Do you ever integrate sort of that combination that Vic and I are talking about into your surgical patients as well?
Yeah, absolutely, all the time. We were just speaking before we were on. I did my fellowship in a big group in Dallas, and there were a lot of facelifts happening and a lot of excisional procedures happening. And I think, surgery, it's no matter how good you are, you're going to get some recurrent jowling. You're going to get some neck laxity. And sometimes that happens, after 3 or 4 months, and it's a real challenge because what are you going to do? Take the patient back to the operating room? Who's going to cover the OR anesthesia expenses? So radio frequency actually for a revisional procedure is actually, I find, to be really helpful for both body and face contouring, just to help kind of remodel that soft tissue and tighten things up without another operation.
For some of these procedures that we're talking about for laxity, a lot of times you actually have to demonstrate to patients their improvement in a before and after photo. But there are certain specific uses of bipolar fractional radio frequency, for instance, acne scars, where I think the patients realize very quickly that they're having improvement. And Vic, from your perspective, what are really the best uses where you can see significant improvement from a radio frequency type of device?
I think the place where I see it the best, I'd say acne scarring number 2, the place I see it absolutely the best is when I do radio frequency microneedling, usually in the corduroy-like lines or Venetian blind lines that people get in their mid-cheek area, these vertical lines. If I do 2 or 3 sessions with aggressive settings, I tend to see pretty good results that are easily identifiable in photography. You don't have to move the camera a certain way or have photographs with different lighting. It's that obvious. And that's where you get the most bang for your buck, particularly if you combine that, which you oftentimes do, with even a device that's very gentle, like a Fraxel procedure, either 1927 or 1550, and also always address the red and brown dyschromia with something like intense pulse light, KTP laser, pulse dye laser, all in the same session. Because then those patients get the immediate gratification of the skin looking fresher and better, and they wait for that delayed effect for the radiofrequency tightening to kick in.
So I agree with you. And as long as we're using specific brand names, as you indicated, in terms of these Venetian blinds or secondary smile lines or accordion lines, I think, in our practice, we use the bipolar fractional Genius RF system, which is an intelligent care type system. I know you've been involved with that as well. This is something where there's insulated needles, so you can feel comfortable treating all skin types with that. However, this is something where really it tells you in terms of your contact with the skin, if you have appropriate contact. It tells you a lot about your settings and the area under the curve. So can you talk to us a little bit about making sure you're doing this safely, you're using it for different skin types, and how you know you're actually effectively delivering this energy?
Well, that's a good point. There are several radiofrequency microneedling systems out there, and most of these are pretty good systems, but oftentimes you're relying on the system display to tell you what's happening, and that is not always what's happening, particularly as far as needle penetration. So one of the first, I think, ideas is you have to have the needle penetrate as deep as it says it is on the panel. And the second thing, which you referred to, is you have to make sure you're delivering the full complement of energy and not less. So some devices tell you if you're delivering like 2.5 joules per pulse or 3 joules per pulse, and gives you a signal that you're doing that. And then you're sure and confident that you're placing all that energy in there. So the critical thing is watching the needles go in, at least getting 80 or 90% of what the depth is supposed to be, and having some algorithm for ensuring that all of that energy is invested in the skin and not wasted.
So, and Dr. Dayan, in your fellowship with the great plastic surgeons at UT Southwestern, with Jeff Kenkel and Jay Burns and Rod Rorick and team, you did some work on the Evoke system, and which is a bipolar non-fractional radio frequency device. And it is something that there's no significant discomfort, and it's actually hands-free, right? You don't need an assistant. So can you talk to us about some of the work you've done on this system, which is different than the microneedling systems we're discussing now?
Right. So, it's kind of interesting. We had the Evoke system, which is basically a non-invasive, hands-free face contouring device. And we've had it for about a year. And to be honest with you, as a plastic surgeon, I always feel that the less invasive you get, the less of a result you get. That's always been my kind of sense. But what's interesting with radio frequency is there's kind of an Arrhenius relationship, time-temperature relationship, where, on this bell curve, you can either heat tissue at a very high temperature for a short period of time. And an example of that would be like J plasma, for example, high temperature, short period of time. Or you can heat tissue at a lower temperature for a longer period of time and get a similar soft tissue contraction. So what I think Evoke has really accomplished is delivering bipolar radio frequency in a non-contact fashion with very tight temperature control, consistently over a long period of time to gain a soft tissue contraction. We've actually seen quite impressive results with it over time. So, for the patients that don't even want a needle stick, don't want any kind of radio frequency microneedling or bipolar radio frequency with the face-tight Accutite, for example, we really employ the Evoke and get nice results with it.
So for folks out there who may have Ultherapy and microfocus ultrasound type of devices, how does this stack up? Because actually I see this as potentially complementary, where you have radio frequency leading to its mechanism of action and heating, and hopefully improving the laxity along the jawline and the neck with these two adapters that are fit onto the Evoke, and then Ultherapy being used above and below, as well as in that area at a different visit. What are your thoughts on that?
Well, I will admit my experience with Ultherapy is somewhat limited, but from what I've seen, it does tend to be a little bit uncomfortable for patients. So that's one limitation. One thing I like about the Evoke system specifically is that, as we age, it's really the lower third of our face that's the main issue. Our face goes from kind of an upside down triangle. We have high cheekbones, tapered jawline, and as we age, it becomes more like a right side up or square lower face. The jowls and the submental area are kind of the main issue. And that's where kind of mini facelifts kind of target those areas specifically. So the nice thing I think about, the Evoke, the nice thing about it is it kind of targets exactly those areas, the jowls and the submental laxity. And what I like about bipolar radiofrequency specifically is that it's very directional, it's very controlled. There's very close temperature monitors on it. So I don't feel uncomfortable leaving a patient connected to the device. I know that it's heating efficiently to 40 degrees Celsius. And over 45 minutes, I know after a couple sessions, they're going to see some soft tissue contraction.
So no discomfort, no employee or staff member, team member in the room monitoring the patient,
Right.
But you do need to make sure that this is a good fit and it's completely opposed to the skin edges. It's not lifting off in any area. So when a patient animates or speaks or something, this could actually move a little bit. So you want to make sure to check on them and check that connection, right?
Absolutely. It's good. It's a very good point, because when we were first dealing with the prototype devices, that was a big consideration. Not everybody has the same bigonial angle. Everybody's face is shaped differently. And, the device has some safety settings. So if there's poor contact, that electrode won't fire. So that's helpful. But it's definitely nerve-wracking to leave a patient in a room with the device connected. They do have a safety button that they can pause the treatment at any point. So that's reassuring. And, in the beginning, I was hovering by the room and making sure, everything's going smoothly. And it's surprisingly comfortable. I find it to be surprisingly comfortable for what it can achieve.
So, and then Dr. Ross, we touched on the fact that most of these radio frequency devices, as well as microfocus ultrasound, do require patients to have some form of pain mitigation strategies. Can you talk to us about the ways that you are able to get patients through some of the procedures you do, including bipolar radiofrequency, as well as things like resurfacing?
Yeah, so it depends on what kind of bipolar model you're talking about. There are some models where you move this electrode around, these bipolar rail systems, and those don't require any anesthesia. In fact, you don't want anesthesia because you're relying on that temperature feedback either with the machine or patient discomfort. But for the other two cases, the micro needling with radiofrequency or with resurfacing, we have sort of a sophisticated protocol that works really well. For the full face resurfacing, which we just did today, we have a protocol where the patient comes in, we use numbing cream, 5 milligrams of Valium. Then about 45 minutes later, they receive 50 milligrams of Vistaril and 50 milligrams of Demerol IM. And then they receive some injections, supraorbital, supratrochlear, mental, infraorbital blocks. And then we use these mesoram needles, which are on one of these slides. And the mesoram needles we use are the 5-prong model. In this slide, there's a 5-prong and a 3-prong model. And we inject those for the areas that are not going to be covered by the blocks, which typically is the neck and the lateral face. I always tell people it's sort of the area that if you were just sitting here wondering about something, that's the area that doesn't get covered by the blocks. I always tell the fellows that's the area we have to cover with the mesorams. And there we use a tumescent solution, 0.24%. And that's, it sounds like a lot, but actually patients, particularly if they have this little mild sedation where they're walking and talking, it's like having a couple of glasses of wine. They're comfortable and they actually respond very well to the treatment, much better than my treatments with Fraxel, where I just try to get by with topical. So I think the patients are quite comfortable with that sort of compound in that series of events we use to make them comfortable. If something's very light, we don't need quite as much. If we're doing, for example, Genius, and we're doing a really small area, we'll just use a little local. But I found that topical anesthesia for the aggressive microneedling radiofrequency system simply is not sufficient.
So, we do it very similar to you. We also have a Pronox system so that we can sort of make people feel a little bit more comfortable. And, my wife actually gets some of these treatments done. And for her at 102 pounds, I think that the Pronox has actually worked pretty well. So she said, honestly, it feels like she's had a couple drinks and she's aware of the procedure. It's not something that really bothers her. Erez, I know with the Evoke system, you indicated that there's no discomfort, but typically when you're incorporating other types of technology into your practice, what type of anesthesia are you preparing patients with?
I agree with Dr. Ross completely, actually. I did the Morpheus radiofrequency microneedling for a long time, and it's very patient dependent. Some patients have a really tough time from a pain standpoint, and some patients are fine. I'd say majority of them do feel some discomfort, and topical kind of does fall short. So in those cases, we've incorporated Pronox and a little bit of diazepam. And but I do think blocking is probably a good idea, and mesorams is, probably also a good idea, because you never want to fall short on the actual treatment, because of pain.
So, and I want to wrap up just talking about wound healing and anticipated responses. So, we obviously have patients try to realize that they're a co-participant in their care, and that we do the treatment in the office and they need to follow instructions when they go home. There's a lot of things that patients don't necessarily think about. So after microneedling type of bipolar radiofrequency, there are portals of entry into the skin. And when patients in this era are wearing masks all the time, I really encourage patients to try to understand that there are multiple sources of contamination, from their hands to things that they touch that may touch their face, like their pillowcase or toweling, or to their hair, to the mask itself that they're wearing, where patients may be inclined to wear the same mask every day and not realize that there's makeup debris and nasal secretions and oral secretions on that. So for the types of radiofrequency treatment where there is microneedling associated with it, as well as other things like resurfacing, talk to us about some of the tips that you use to explain to patients and have patients really do wound care that's very diligent and careful. Dr. Ross.
No, you're right. Obviously, resurfacing is a whole different ball of wax. When we do that, we have to do the full complement of typical Valtrex and all kinds of topical. We usually use topical antibiotics now, not oral antibiotics. But for RF microneedling, we typically don't do anything too heroic. We just make sure the skin is clean beforehand, usually using hypochlorous acid and maybe some alcohol. And then we just tell patients that they're very slight risk of infection, because these wounds are actually closed wounds in a sense. But we just have them, just don't go in the ocean swimming, things like that. But for most people, after microneedling with radiofrequency, they can do most of their activities so long as their social situation permits it. If they're swollen and oozing a little bit, maybe an hour or so afterwards, a little bit of bleeding, obviously they can't do everything. But the wound care we found is pretty simple for the microneedling. Certainly for the non-invasive like Evoke, or some like the Fractoriformer, for example, or the Axilis devices, you don't need to do any wound care at all.
And Erez, what do you tell your patients? I know you're often doing a surgical procedure on them as well. So how does this go?
I agree with Dr. Ross. I think, with radiofrequency microneedling, oftentimes there's not much of an injury at the skin level. It's kind of like a pyramid, because the heat is concentrated more deeply. When I do, there are radiofrequency microneedling tips that are very superficial at 0.5 millimeter that do give you actually more of an injury to the skin. And so what I tell people, what we used to do is have them ice, and I actually think that's kind of backwards, because when you look at their skin with a thermal camera, they really retain that heat for some time after the treatment. So I actually ask them not to ice. I just have them wash their face with, water and a gentle soap. And something that's kind of been a game changer for me in the last couple months has been using oxygenetics. I don't know if you guys are how familiar you are with oxygenetics, but one of my friends that's a dermatologist recommended it for post-treatment kind of foundations. And I'm sure there are other companies that do it as well, but it's worked nicely for us to cover up the redness, and we can get a little more aggressive with the more superficial treatments and not worry about the patients looking too battered afterwards,
So, and Vic, as you indicated, we use a lot of hypochlorous acid in my practice. We use the Laserson formulation. We use it before the procedure. We use it after the procedure. And, honestly, that has been really helpful. As a person who does a fair amount of Mohs surgery every week, we use this as a skin prep as well, particularly in the periocular area. So a lot of times these patients that are having periocular procedures, whether it's filler or whether it's surgery, they don't appreciate the betadine discoloration and the residue on the skin for several days. And with hypochlorous acid, we really get around that. Plus it's eye safe, so completely eye safe. So when you're really prepping the patient really well for any procedure, including fractional radiofrequency with microneedling, it seems to work really well in our practice. So from the final perspective, we have a plastic surgeon who does blepharoplasties and brow lifts on a regular basis. And then from your dermatologic experience and my dermatologic experience, a lot of patients are not only interested in lower face recontouring and submental recontouring, but really brow lifting and the degree of dermatochalasis that they have and the brow lid redundancy. So obviously, Erez, there's patients who you look at, you think, that patient's really going to need surgery. And then Vic, we look at some patients and say, I think we can give them some improvement with a different type of device. In some cases, that may be all therapy. In other types of cases, it may be a radiofrequency. Brian Beisman, who's one of my close friends, really helped innovate Thermage's probe for use around the eyes. So, Vic, talk to us about how you approach the non-surgical candidate for periocular rejuvenation.
Yes, so the only non-invasive thing I found even a little bit helpful is there's a small device what you rotate around. It's a bipolar radiofrequency device. IndyMed makes it as a small eye tip, and that's completely non-invasive. You just go to 40 degrees, you stop, you whirl it around the eyelids, but marginally helpful. The next step is to do radiofrequency microneedling. What I found I'm doing more of now is this Agnes device, where you pick a tip. It's monopolar. You have a return electrode, and it has 3 electrodes around the eye. They have different letters, WB3, but you insert the needles into the eye area. There's one for eye bags, and there's one for eye tightening. The one for the eye bags is about 2 millimeters deep, and you just go around 30 or 40 insertions. This requires anesthesia, injectable anesthesia, but patients do quite well. It does beat them up a little bit. You might get some bruising, so there's no open wound, but you're not going to look great for a while. And of course, the third step, if that's insufficient, the patient wants to do more, is periorbital resurfacing. Typically, I use the CO2 laser for that.
So in Erez, there must be patients that really come in that tell you they want to avoid surgery, but you look at them and say, let's be realistic. You have a lot of lid brow redundancy and you're a better surgical candidate. How do you handle that conversation?
I think it's actually a really challenging area, and I owe a lot of credit to Dr. Kami Parsa in Beverly Hills, oculoplastic surgeon, that really kind of taught me a lot about this. But I agree with Dr. Ross. I think CO2 in the lower lids for that skin redundancy is actually probably the best thing, just to tighten up that skin non-surgically. As far as brow lifting goes, to be completely honest, I haven't really found any minimally invasive device to really meet the mark there. And to be honest, even surgical brow lifts oftentimes either look unnatural or fall short. So I think that if you polled a bunch of plastic surgeons, brow lifts even have kind of started falling out of favor. Upper eyelid blepharoplasty is just a good procedure and it works well. So it's one of those things. The only place where I've really found in the periorbital area radiofrequency to be particularly good has been the lower lid, lower lid fat pads. And what we use there is the Accutite device, which is nice because it fits through an 18 gauge needle poke. It's a bipolar radiofrequency device. You put it right on the periosteum and, it'll melt some of that SOOF fat. So your postseptal and the SOOF, and you can help, with patients with moderate, lower lid fat pads, you can kind of melt those away safely. And we've done a lot of the anatomic studies on that. So that's the periorbital area that I think is most affected with radiofrequency.
Well, I want to thank both of you very much, Dr. Vic Ross, Dr. Erez Dayan. It's great to have you both with us, sharing your knowledge, and it's super to have the complement experience in terms of a dermatologic surgeon and a plastic surgeon. And we appreciate all of you being with us for Scientifically Speaking in conjunction with Modern Aesthetic Magazine and Practical Dermatology.